Everyone. Welcome to Grand Rounds. Thank you so much for joining us today. Today we have Dr. Andrew Francis with us. We're very honored to have him. Let me read his bio very quickly so he can get started. So Dr. Francis completed a PhD at SUNY Stony Brook in New York, followed by postdoctoral research in neurobiology at Cornell University Medical School. He obtained an MD from the University of Buffalo, followed by a psychiatry residency at Johns Hopkins Hospital. He was the co-developer of the Bush-Francis Catatonia scale, the standard clinical and research tool to detect and quantify catatonic symptoms. He is a recognized authority on catatonia, neuroleptic malignant syndrome, ECT, and delirium. Dr. Francis is widely published in these areas and has presented at regional, national, and international medical conferences, as well as serving as invited lecturer at many academic medical centers. Currently, he is a professor of psychiatry, associate director of residency education, and director of neuromodulation services at the Penn State School of Medicine at Hershey Medical Center in Pennsylvania. Please welcome Dr. Francis.
Well, thank you very much for that generous introduction. It's my pleasure to be here, and greetings from Pennsylvania. This is Hershey Medical Center in summertime. It looks very different right now. And I'll be talking today on catatonia, and I hope it's a review. And I'll tell you what we've been focusing on more recently. I'll introduce you to the topic and tell you what we've been focusing on more recently. So I have no disclosures. I'm a full-time Penn State employee. Anything I say is my own opinion here, not the official opinion of the institution I work for. And I'll be talking about off-label treatments for catatonia. There are no off-label medications for catatonia. There is an FDA-approved treatment for catatonia, which is ECT. The medicines that we use for catatonia are FDA approved for other things. I do have a website, catatonia.org, and that has a lot of information. It has some of the same videos I'll be showing today. And I do recommend that if you're interested in learning more. So it's customary in academic talks to harken back to the European psychiatrists of a former era, what some people might call dead white European males. And in the case of catatonia, we look back further than Kraepelin, who is the father of modern psychiatric diagnosis. So Karl Kalbaum was a psychiatrist in the 1800s in Germany, and he left academia and became the superintendent of a asylum, psychiatric institute, in what was then Eastern Germany, where he worked for 35, 40 years. And about 10 years in, he published a monograph in 1874 describing some unusual patients that he'd seen, and he named this syndrome catatonia. In German, I'm going to butcher the German here, Spannungserregung, tension, insanity, referring both to the psychological tension that the patients seem to be experiencing, as well as the motor tension that many of them have in terms of muscle rigidity. So these are consecutive paragraphs from the monograph of that, from the introduction to that monograph, which contains, I think, 25 or 26 case histories. Some of them are greatly detailed. And he notes that the patient remains motionless without speaking, rigid masked face, blank stare, seems devoid of will. This concept in the German literature of will, which doesn't translate well into English, perhaps somewhere between motivation and drive to move or react. It can be fully developed or only partial, which is an important thing to recognize. Impression conveyed is one of mental anguish and mental shock, which you often don't hear about later because mutism, that is to say not speaking, is a common catatonic sign. But many patients, not all, will describe unpleasant experiences during that period they were catatonic. Tends to be persistent, although in some patients it can come and go. We have a paper in Press on fluctuation of catatonic signs, which we can talk about if you'd like. And Kalbaum, who's writing in the 1870s about patients he'd seen over the past 10 years or so, makes note that catatonia is associated with medical illnesses, and he's calling them muscular disorders. We would call them neurological disorders. Neurology was not very far advanced in this period. Broca had published on expressive aphasia in 1862, and Wernicke was actually later in the 1870s on receptive aphasia. So Kalbaum called them muscular disorders. We would now call them neurological disorders. And what they were primarily, as can be ascertained best as we can ascertain from his notes, is epilepsy and neurosyphilis. So important things about catatonia really were identified by the first person that described it. And all of these observations have been confirmed in later research. So I got interested in catatonia a little bit more than 30 years ago when I was at SUNY Stony Brook in Long Island, New York, where I was for 25 years before moving to Penn State. And I was an inpatient provider and inpatient director at that hospital, University Hospital in Stony Brook, Long Island. And on the inpatient unit, we had a patient who was catatonic. We struggled to treat that patient. We didn't know a lot about catatonia. Not much literature with respect to treatment and diagnosis had been published that was of use clinically. And a resident whose name was George Bush, he thought his troubles would be over after George Herbert Walker Bush was president. So we had this patient, and Dr. Bush was a resident on the service. We were struggling to treat this patient, and Dr. Max Fink, who will be 101 years old in a couple of weeks, was active and director of the ECT service at the time, and he told us ECT would treat catatonia. You should give that patient ECT. So Dr. Bush, patient had no family. Dr. Bush went to court for a court authorization for ECT, which was necessary in New York. Patient did very well with ECT. This was a 45-year-old woman. And after that successful treatment with the ECT, Dr. Bush approached me and Dr. Fink and said, this catatonia thing is very interesting. We didn't know a lot about it. I want to study it. And I told him, you can't study something unless you have a way to measure it. And the result was the catatonia rating scale that when we published, we named for ourselves. And we published a two-paper set 25 plus years ago now. The first paper described the rating scale, how we derived it, its characteristics, its psychometric properties, things you do when you create a rating scale, and the characteristics of a prospective sample that we identified on our inpatient unit. So after we constructed the rating scale, we prospectively identified patients on our adult psychiatric inpatient unit, cohort of 28. Second paper, which was published as a set, described the treatment outcome for those patients. And in that paper, we first described what is now known as the lorazepam challenge test. And it was the first paper showing quantitative response with a well-characterized rating system for catatonia. So that paper on the rating scale has been highly cited in the research literature. It's over 1,000 citations currently, which reflects an interest both in research and in clinical care and clinical recognition of catatonia, which is gratifying, but still actually misses the mark. It's often missed or misunderstood. So both in research literature and in clinical care, the rating scale is commonly used. It's been installed into electronic health system records, electronic records in health systems, for example. And it's commonly used in clinical practice, been translated into many languages. It's freely available on the web. If you search catatonia rating scale, this will come up. I should mention that in addition to that rating scale in that first paper, we included a systematic standardized way to assess the patients to help improve reliability. So we arrived at a rating scale with 23 items. Most of those items actually came from Kalbaum. Some of them were added by later workers. And we selected them based on their frequency and to also include, we knew at the time there was a hyperactive and a hypoactive form of catatonia, and we included items for both. We can talk more about how we selected those items if people are interested. So we arrived at 23 items, which was reasonable for a rating scale. It's similar in size to other rating scales used for mood or cognition or psychosis in psychiatry. And we wanted a rating scale that could be used to make a diagnosis and also to monitor severity in terms of outcome and treatment studies. So in psychiatry, we have clinical syndromes, taking a concept of a syndrome as a collection of signs and symptoms that occur together, persist together, and go away together if it's a reversible syndrome. We make diagnoses in psychiatry based on number of signs and symptoms. So for example, in major depressive disorder, the current DSM requires 5 items out of 9, for example. And likewise for many other diagnoses. So we wanted to capture mild cases, so we set a low criterion, a low bar. And that bar we set was 2 signs out of the first 14 items. So caseness would be defined by number of signs. In our original studies, 2 signs, which is perfectly good for psychiatric patients. The DSM has a similar list, 3 signs out of 12. That's perfectly good for psychiatric patients. For medical settings, patients in medical settings, especially in the ICU, a higher bar is needed. I'll explain the study that showed that. And that would be 4 signs out of the first 14. And then to rate severity, so caseness would be at least 2 of any severity out of the first 14 being present. A typical patient in a hospital setting has at least 5 or 6 of them. And then severity would be rating all 23 items on a 3-point scale. So 23 times 3 is 69, the maximum score. Typical patient in a hospital setting would be somewhere between 15 and 25. It's rare to be above that, but we do see them. Most of these catatonic signs are observational. That is to say, the examiner does nothing except look at the patient. So for example, immobility, they don't move. Staring, they have a vacant stare. Grimacing, they have movements of usually the lower face. Stereotypy and mannerisms, they have persistent repeated movements of one kind or another. Verbigeration, they repeat in their speech. Some of the catatonic signs are elicited. That is to say, the examiner does something to induce the sign. So for example, echopraxia and echolalia. Echopraxia is the patient mimics or imitates the speech, movements and behavior of the examiner or of someone on the TV or someone in the room. Echolalia is they mimic the speech of the examiner or the TV or someone in the room. And some of them are based on physical exam. So for example, rigidity, waxy flexibility, and Gegenhalten, those are all abnormalities of motor tone. Again, a diagnosis made by the presence of at least 2 in psychiatric patients and 4 in medical patients. And the DSM-5 is a major advance over prior DSMs in that it has a similar list. It's missing a couple of important signs like staring and rigidity. And the DSM looks for 3 out of 12. The DSM-5 is an advance in that it attempted to at least define these symptoms, although there's no severity listed. Our rating scale has a severity. And here's the list of the 12 DSM-5 signs. And again, the DSM-5 is 3 out of 12 to define a case. No severity indicated. Some of these definitions, though, I think are challenging. So for example, stupor, not actively relating to the environment, and negativism, no response or instructions to external stimuli. I think those would be confusing. So I think for psychiatric patients, it's perfectly okay to use the DSM criteria, but the definitions of the signs are better on the R rating scale, I believe. As I mentioned, we developed a standardized exam, a systematic way to assess the patients, and this was in an attempt to improve reliability of the rating scale and a sequence of ways to assess the patient. that could be done within a 5-minute window, because we knew that sometimes treatment could be rapid. So we wanted an assessment that could be done within a few minutes. This is also available on the web. With that operational definitions, each of those signs had an operational definition and systematic definitions of severity. So with those operational definitions and careful definitions of each sign, as well as the standardized exam, it becomes a scale that's highly reliable. That is to say, different examiners examining the patients tend to get very close to the same score. And this was all published. The kappas for agreement, for example, are 0.7 and above, both for assessment of caseness and severity. And that's been confirmed in later research by other workers, that it's a highly reliable rating scale. Validity, of course, is more challenging in psychiatry to assess validity of a psychiatric test or a diagnosis, but patients identified as having catatonia by our rating scale or by the DSM have a high rate of response to catatonic treatments. So in a sense, that's a validation. So it's possible some people in the audience have not, with that as an introduction, it's possible that some people in the audience have not seen catatonia or haven't seen it lately. So I want to show some examples of what it actually looks like, including in the developmentally disordered population, which is kind of a focus of interest lately, of increasing recognition of catatonia in autism and intellectual disability and other developmental disorders. This is a textbook, actually, I believe, from one of Kraepelin's, a picture from one of Kraepelin's textbooks from the early 1900s. A patient that's showing posturing. So I have a few videos I want to show. They're short segments. They're all black and white grainy videos. That's not a defect on the computer. So these were made, I believe, in 1930 or 1931. This first one is, anyway. And they were made by, they're available from the National Library of Medicine. They're in the public domain, but they're actually real patients, historical patients from 90 years ago. And they were made by Dr. William Blequin, who was a psychiatrist at the University of Wisconsin, who is the inventor of the first treatment for catatonia, which was a barbiturate, sodium amylbarbital, more commonly known by its brand name, which was sodium amytal. And he discovered that this compound relieved catatonia, which prior to that had no treatment. And the treatments were so dramatic that he made some videos of several patients. I'm only showing one here, and I'm not showing after treatment. But the patient does resolve completely with the barbiturate, although the effect wears off. So this is a real patient, and it's an example of a very severe form of catatonia that would be hard not to notice. And I think I have a narration on this. And this video is also available on my website. So the doctor's on the left, the patient's on the right. And I believe I have a narration here.
Where it was previously placed. Posture, where his arm remains in an upright posture. So his arm remains in an upright posture where it was previously placed. And you can see that the examiner moves the limbs and they stay in unusual postures, which may persist for long periods of time. And notice how the whole body seems to be rigid. There's no fluidity at all to the man's posture. He may remain in this unusual rigid posture for extended periods of time. He's not talking to, he's the examiner. He also shows mutism, another catatonic sign. And he's blankly staring, not really engaging with the examiner, who is moving him around. We'll see a close-up of his face here. And you'll notice that he's blankly staring, he's mute, he doesn't engage with the examiner. So it's staring, mutism, withdrawal, rigidity, and catalepsy. Multiple catatonic signs that are all...
Okay, did the video and sound come through okay on that?
It came out perfectly.
Okay, here's another example. This is a little bit later. This is now the 1940s. And these are some patients that apparently are outside the hospital in the yard. They're real patients. Again, this is in the public domain, available on the web. So in catatonia, there's a hyperactive form, and among those hyperactive signs are mannerisms and stereotypies. They're both repetitious movements. We attempted to split a hair and define them. So we conceive of mannerisms as repetitious movements that are odd the first time you see them. They often involve parts of the body used for communication, the hands and the upper body and the face. And as a New Yorker, I would say you wouldn't sit on the subway next to somebody with mannerisms because the movements they're making seem odd the first time you see them. But you might very well sit on the subway next to somebody with stereotypies where the abnormality is in the frequency, not the nature of the movement. So for example, rocking would be a stereotypy, most likely. This one has no sound. So you'll see that the man makes a sequence of movements in a highly ritualized kind of fashion. He touches his lapel, his coat. He seems to be moving some piece of paper between his hands in sort of a ritualistic way that looks odd the first time you see it. And we'll see a close-up of his face. He actually has grimacing. In the modern era, we might say this is tardive dyskinesia. This was done in the pre-neuroleptic era. So you notice some grimacing of his face. And again, he has that sequence of odd movements as if it was a private ritual. So they look odd the first time you see them. So we would class those as mannerisms. Echopraxia, as I mentioned, patient repeats, mimics the movements or posture in this case as well of the examiner. So same thing, this is a patient out in the courtyard of the hospital, apparently, sitting on a bench, female patient, and she's sitting next to a doctor. And you'll notice she mimics the exact same posture he's sitting in, and then as he makes some movements, she mimics those same movements imperfectly. So she sits with her legs crossed and her hand on her chin, as he was doing. And then he makes some movements and she repeats them without being asked to do so. Perhaps over enthusiastically. She might actually have mania, it's hard to say. But this would be an example of echopraxia. Now, as I mentioned, there's increasing recognition of catatonia in the autism and other developmental disorder population, both in children, adolescents, and adults. And we've published on this, and we treat several in our ECT service, as well as in the Autism Center at Penn State. So these are not patients. I'm going to show 3 examples. These are videos posted by families saying, this is our child with autism. That's all I know about this young person. So obviously I can't make a diagnosis of someone whose video was posted on the web by the family. But it's in the spirit of saying, should a child appear in the clinic and show such behaviors, possible catatonic signs could be entertained. So it's in that spirit that I'm showing these videos. I'm not diagnosing this child. I'm saying, should a child appear with a developmental disorder showing these behaviors, we could entertain catatonic signs. So what will be notable here is that this young person, looks like a teenager perhaps, seems to hold his left hand in a posture. His right hand has repetitious movements that I would call a stereotypy, and so does his head and neck. So it looks like, were he in the clinic, he would have posturing of the left arm, stereotype movements of the head, neck, and right arm. He's also not speaking, so that could be mutism. Now, I also noticed that a woman walked through the background, perhaps a grandmother, and there's a gentleman sitting here in a chair who's not saying or doing anything, which would indicate to me that these behaviors are chronic. They're not something new. Now this child is going to use I think a spoon to pick up some food. And you'll see he gets stuck in the middle of doing that, both in halfway up to his mouth and in his mouth. So this could be, were he in the clinic, a catatonic sign ambitendency, which is a motor hesitancy or a motor stuckness. So stuck in the middle. And the spoon is stuck in the mouth. Notice the left hand remains in the parent posture. So were he in the clinic, catatonic signs could be entertained of stereotypy, posturing, ambitendency, and mutism. Here's another example, same thing. Family posted a video online saying, this is our child with autism. There's a girl here on the right wearing a sweater and a caregiver of some sort, an escort. They're in the house. They're going to walk outside down the front steps out onto the sidewalk. And in the same spirit, were she in the clinic, the following catatonic signs could be entertained if such behaviors were seen. So it's in that spirit that I'm saying these things. So you'll notice she pays no attention, has no interaction whatsoever with this caregiver. Her arm remains in an upright posture, which would possibly be catatonic posturing. Mutism, withdrawal, because she has no interaction. Once outside, she turns in a circle, which could be a mannerism, and rubs her hands together, which would be a stereotypy. And again, has no interactions with this escort. So possible catatonic signs here, were she in the clinic, would be posturing in the right arm, withdrawal, no engagement with the caregiver, stereotypy, which was the rubbing of the hands, not unusual, just that it's done too frequently, and mannerisms, which are odd the first time you see them turning in the circle, and mutism, she doesn't speak. So this could be an example of catatonic signs in a person with autism. Third example, same thing. Family posted a video online. This is our child with autism. No, nothing else except that. Same spirit, not making a diagnosis, saying that should a child appear in the clinic and show such behaviors, possible catatonic signs are indicated here. He appears to be much more severely afflicted. He's wearing protective gear, which would imply to me that he's got some self-injurious behaviors. Sometimes self-injurious behaviors are in a stereotype fashion and respond to treatment when recognized as catatonic stereotypy. And there are plenty of examples of that. Dr. Lee Wachtel at the Kennedy Krieger and Johns Hopkins has published a case series on severely affected children that appear like this, who are recognized as having catatonia and respond to catatonia treatments, often with dramatic improvements in their life. So he's going to show a sequence of movements, which are probably a mixture of stereotypies and posturing. Were he in the clinic? He doesn't speak. He's in constant motion. So he has what appear to be a ritualized sequence of movements, including posturing and stereotype movements. Doesn't speak, and he's in constant motion, which is a mild form of excitement. So were he in the clinic and showing such behaviors, those catatonic signs could be entertained. He may have staring, it's hard to tell, but he doesn't speak. Highly ritualized mannerisms and stereotypies. I'll show one example also of another phenomenon that may represent catatonia, which is excited delirium. So excited delirium is a category that I believe exists, but the American Psychiatric Association and I believe the AMA don't believe it exists. These are people found in the community with a severe mental illness or intoxication on a drug who have extreme agitation. And it's a very controversial diagnosis because these people often end up in bad shape because of how the police handle them. And in any case, this is from a emergency EMS training site that we found of a person who's agitated, apparently, and the EMS team is called to the house. Presumably, he later agreed, the patient must have later consented to this being posted because it's on a publicly available EMS training site. And we've edited it to show certain possible catatonic features. Same thing. I'm not making a diagnosis. I'm pointing out from a publicly available video possible catatonic signs, which I think we list on the slide.
I just don't want him to get free if he.
So he's mute with staring.
Yeah.
At this moment.
Have him get the suit stretcher. We can do that.
Sure. As long as we can secure him to
With
it.
strap. Plenty of strap.
Refrigeration.
It's okay.
Feeding.
Don't fight it.
And please, and I tap my hand, I fought. Please, and I tap my hand, I fought. Please, and I thought.
We're gonna get you to the hospital.
Please, and I taught.
Relax.
Please, and I.
Here's some episodes where he's agitated.
Yeah, that's fine.
I'm gonna turn the bus, come on, I'm turning the bus, come on. I'm gonna turn the bus, come on, I'm turning the bus, come on. I'm gonna turn the bus, come on, I'm turning the bus, come on.
Nobody's. Just relax. Lay your head back and relax, Tim. Tim, lay your head back and relax. Just.
That kapush could be a mannerism of speech. Of note, when I was in New York, we looked for the agitated catatonia in our psychiatric emergency service. So we prospectively screened consecutive referrals to the psychiatric emergency unit at Stony Brook, where we were at the time, 249. And the question was, is agitation, we characterize agitated catatonia, excited catatonia, but along the way we assessed whether agitation itself was a risk factor. So we measured agitation on the Udosky agitation scale, and we measured catatonia using the Bush scale with 2 signs as a criterion. And what we found was that 7% of these psychiatric referrals to the emergency service had catatonia, but there was a 4-fold increase among agitated patients. So agitation itself is a risk factor for catatonia. So I have other videos on my website, and I would draw your attention to learn more about catatonia from the University of Rochester Catatonia website, which Dr. Mark Oldham manages, and I collaborated with him on this construction and materials on this site. It has a variety of instructional materials. It has simulated patient videos for all of the catatonic signs. So is catatonia a relic of the past, or is it something that we still see? And this was a paper we published in the attempt to influence the DSM-5. So the DSM-5 came out in 2013. We published this a couple of years prior because the initial work groups for the DSM-5, it was assigned to the catatonia was assigned to the psychosis work group, even though I don't believe it's a psychotic illness. At any rate, their initial take was that the catatonia doesn't exist and there's no need for a code, a diagnostic code. So what we did was we reviewed 20 years worth of prospective studies of psychiatric inpatients, some done in Europe, some done in Asia, and some done in the United States, around a global sample, so to speak. Most of the studies after 96, here's our study, Bush et al., use our rating scale. And these are adult psychiatric inpatients, and slightly different methods of how in populations, but on average 9% of people admitted to a psychiatric unit will have catatonia, depending upon how it's defined, of differing severities, of course. But what we highlighted as well, so it does exist. And secondly, perhaps some way more importantly, majority of patients, 2/3, will have mutism. That is to say, they don't speak at all or speak very little, which means it's hard to do a mental status exam on them. And as well, more than half will have negativism or withdrawal. Withdrawal is passive, passively not engaging with the environment. Negativism is actively resisting engaging with the environment. So they will commonly be mute or largely mute, and they will be withdrawn or resist attempts to engage with them. So not only will they be catatonic, but it will not be possible to assess them for anything else. That is to say, do they have an associated psychiatric illness like mania or schizophrenia or delirium? And so the argument we made was we at least need a provisional code to recognize this person has catatonia, which would guide some sort of a treatment and perhaps an appropriate workup. I don't know if they listened, but they did eventually provide a code that can be used for catatonia, and it can be attached to psychiatric illness and medical illness, which was a major advance. So what about medical populations? And I'm going to finish with the medical population specific to delirium today. So it hasn't been actually well studied. How common, it's not as well studied in the medical population, how common catatonia might be. So these first two papers, they studied pieces of paper, not patients. And what they studied was the records from the consultation service, psychiatric consultation service, providing psychiatric consultations to the medical and surgical parts of their hospitals. So they looked at the roster of patients seen by the consult service, how many of them had catatonia when all was said and done. So it's not a true prevalence, but it does show that it does exist in medical populations. These last two studies actually examined the patients. This first one, Espinola, this was done in Mexico in a hospital. They found 3.3%. They actually examined the patients. However, this hospital was a hospital that caters primarily to neurological patients, and neurological patients are going to be enriched in catatonia. This last sample was done by my colleague, Charles Marmondo, at my former institution. He got them to do a study that I couldn't get them to do when I was there. And Dr. Marmondo and a group of other residents examined every patient admitted to the medical services over a several month period, 718 patients, and found 2.2% had catatonia. And this was using a high criterion of 4 signs out of 14. So it was the higher standard for medical patients. So the prevalence of catatonia by DSM or by Bush-Francis 2 signs would be actually a little higher. So shift now to talking about treatment. So in that first 2 papers, we, from our prospective cohort of 28 patients, we studied the treatment, and we gave them intravenous lorazepam. There were a few case reports out in the literature that lorazepam might help catatonia, but it had not been systematically assessed with a defined protocol or with quantitative results for outcome. So if we could, we gave intravenous lorazepam. And we continued lorazepam for 5 days in this prospective treatment trial at doses of up to 8 milligrams a day. In retrospect, that's underdosing. We've learned since that some patients need higher doses of lorazepam. Higher doses mean 20, even 30 milligrams a day. Obviously not in the first few days, titrated up. So we continued lorazepam by any route, and we did rating scales. Success was defined as no longer met criteria, and failure was they got worse. So this was the results from the intravenous lorazepam study. What's shown here is the full scale score, that is to say, rating all 23 items on a 3-point scale, and the average is 20, typical for a hospital case of catatonia. And after 1 milligram, 5 minutes, dose 1, and a second milligram, 2 milligrams total at 10 minutes. This is a 10-minute treatment trial. And what you see is the catatonia score improves, drops to about 40% of what it was. It's heterogeneous. Some patients catatonia resolves, some patients don't change, but on average, a dramatic decrease in catatonia scores and clinical improvement. So this became the basis of what's now called a lorazepam challenge test, where a patient who is suspected of having catatonia receives parenteral lorazepam and assessed for catatonia. So although it was a relatively small sample, we were able to look at predictors of outcome. So this was a prospective cohort of adult psychiatric patients. Basic demographics and catatonia severity did not predict outcome. This has been shown repeatedly in other studies. Mild case of catatonia, a severe case, can still respond to lorazepam. The diagnosis, whether it was medical or psychiatric, didn't seem to matter, and that seems to be relatively true currently. Not surprisingly, the longer a person has been catatonic, the less likely they are to respond to treatment. And importantly, If they showed a significant drop in their score on the first day, that was predictive of an ultimate good response to the Razepam. So even a partial response on day one is usually predictive of a good ultimate response. And at least in this study, which was under dose did not predict response. In fact, the failures got a higher dose. But again, this was all under dosing in retrospect. Patients who failed the Razepam typically respond to ECT. And that was true in this study as well. This was also the first quantitative data on ECT treatment of catatonia. And that was in that paper as well. So these were 4 patients who failed the Razepam, and even those who fail the Razepam typically respond with ECT. This was bilateral ECT within a few ECT sessions. One patient was atypical here and took several sessions to respond. So in general, what do we know about treatments for catatonia? There does not appear to be a placebo response, although there's only one placebo-controlled trial, and that was from the 1980s. Von McCall did that study. Again, a 10-minute study, intravenous, very similar to how we do the Razepam challenges now. And it was sodium apobarbital versus saline infusions. The saline infusions had no change, and the barbiturates produced a change very similar to what Razepam does. The barbiturate treatment of catatonia has fallen out of favor because of the safety profile of benzodiazepines compared to barbiturates. The first convulsive therapies that were done in the 1930s in Europe were actually drug-induced seizure and then eventually electroconvulsive seizures. This was early 30s. This was 38 rather, electroconvulsive. And as it happens, the first few patients for both the chemically induced seizure and the electrically induced seizure were catatonic, and they responded dramatically, as they do today. And that's part of the reason we have convulsive therapy. Neuroleptics, this is controversial. The older high-potency antipsychotics seem to make catatonia worse. Atypicals are varying literature on that. So there's a risk of exacerbation with neuroleptics. We can talk more about that. There's a whole literature on miscellaneous agents. The most well-established treatments are benzodiazepines, in particular the Razepam, which seems to be better than other benzodiazepines, and ECT. Other GABA agonists, such as zolpidem, have been reported to help. Zolpidem, though, response tend to wane over a few days. There's some evidence for NMDA antagonists, such as amantadine and memantine. We published on this as well. And as I mentioned, atypical antipsychotics, this is questionable and controversial. So catatonia, especially if it's severe and persistent, has complications. And most of these are the complications of not moving, such as other patients who might be lying in bed for an extended period of time or not moving, which is pulmonary embolism, rhabdomyolysis, muscle breakdown, sepsis, primarily from either pneumonia from aspiration or from skin breakdown and pressure sores. All of these things have been reported, less so in the modern era with better treatments and recognition, but they are still risk factors that have to be considered. And so when catatonia is severe and persistent, efforts to mitigate these things should be taken. So, for example, to mitigate the risk of pulmonary embolism, hydration, and perhaps partial anticoagulation, pending effective treatment. So we've been involved in many studies over the years. First, just is catatonia valid as a syndrome? Does it have the properties of a syndrome? And the short answer is yes. It's a collection of signs and symptoms. It comes on together, it persists together, and it goes away together. In addition, we looked at, from our original cohort, patients who got readmitted, came to clinical attention again for a later episode, and it looked the same. It was, in terms of presence or absence of each of the 23 signs, it was 83% concordant. And that's helps validate it as a syndrome, which is to say, if it recurs, it looks similar. We looked at the prevalence and phenomenology. We looked at treatment response. We also published on subtypes, excited, retarded, acute and chronic, benign and malignant. Our example of malignant catatonia was drug-induced neuroleptic malignant syndrome. Discrimination from other motor syndromes. We went to the state hospital in Long Island to look at an elderly sample, average age of 70 plus, and average length of stay in the hospital of 30 plus years. These were elderly patients who'd been exposed to antipsychotic drugs for years. And we went to study this sample because they had high rates of tardive dyskinesia and Parkinsonism, either drug-induced or spontaneous Parkinsonism. And the question was, can you tell catatonia from other motor syndromes like Parkinson's, akathisia, and tardive dyskinesia, using well-characterized research rating scales for those other motor syndromes? And this was a sample, I think, of 45 patients, which we published. And the short answer is yes, you can tell catatonia from these other motor syndromes. And this has been confirmed by other researchers since. We looked at neuroleptic malignant syndrome as a drug-induced form of malignant catatonia. Malignant catatonia means catatonia with autonomic signs, things like fever, labile or hypertensive blood pressure, diaphoresis, a very serious illness that's potentially fatal. And then lastly, in addition to fostering interest in the developmentally disordered population, this question of delirium with catatonic features, which is what I'll finish with today. So I was primarily, when I was in New York, an inpatient doctor, but I would occasionally cover the consultation service to the general hospital, sometimes for weeks at a time. So I was certainly well aware that we would see catatonia on the medical floors and even in the ICU. And I had some dim awareness that catatonia and delirium are likely to be coexisting, but I didn't really do much with it. So another resident who actually did a geriatric fellowship with us, Antonio Lopez Canino, he was on his consultation rotation, and he called me up and said, well, we got 3 people right now who seem to be catatonic and also have delirium. And I saw them and I agreed. And we decided that we would publish this and be provocative. And this was in 2009. And so we published this paper in the Psychiatric Times. It turned out to be a very influential publication. We said, is there such a thing as delirium with catatonic features? And is this a new subtype of delirium? So when we looked at the research literature on delirium, that literature is characterized by many things, and one of them is classification of delirium by motoric subtype. So there's a hyperactive form of delirium and a hypoactive form of delirium defined by levels of motor activity. And there were many studies, different ways of defining these things, which I'll show you shortly, and that these different subtypes seem to be different in their etiology and their course, their morbidity, even their response to treatment and some biological aspects. So for example, there was one study looking at a melatonin metabolite that was different in the hypoactive and hyperactive forms and corrected as the patient got better. And there were some treatment outcome studies that differed by whether these patients with delirium were hyperactive or hypoactive. In terms of etiology, for example, people who have uremia, kidney failure, or liver failure with excess pneumonia, they tend to be a hypoactive form of delirium. People with certain drug withdrawal syndromes, like alcohol withdrawal, may be more likely to be a hyperactive form of delirium. So there were definite differences between clinical and biological, even between these different forms of delirium. So when we looked, and this is a table from the paper, at how these different research groups define this hypoactive form of delirium. So this first one is the confusion assessment method. That's the CAM, which was developed by Dr. Ellie at Vanderbilt, who is a delirium researcher for many years, runs large multi-center federally funded trials on delirium outcome. So their definition from his group is a hypoactive delirium, decreased motor activity, sluggish, staring, staying in one position, moving very slowly. So we mapped this to possible catatonic signs of immobility, stupor, staring, and posturing. This third one, the Memorial Delirium Assessment Scale, that's Dr. William Breitbart at Sloan Kettering Hospital in New York. How does that group define hypoactive delirium? Reduced or slowed movement, rarely moves, rarely speaks, is catatonic. It actually has the word catatonic there. So it seemed that this hypoactive form of delirium by different research groups mapped onto catatonic signs. So we rated the 3 patients that we had on our units that month. And we did a literature search as well, looking for patients who met criteria for both catatonia and delirium on the same day. Most of the ones that we identified had benzodiazepine withdrawal as a basis for the delirium. And the papers, most of them noted that on resumption of the benzodiazepine, both the delirium and the catatonia got better. So we had 3 patients in our case series there in the hospital that we studied. And we had 13 patients from the literature, so 16 total, who all met criteria, and I'll explain what those criteria were, for catatonia and delirium on the same day. The Bush-Francis criteria, and also the DSM-4 criteria at the time for catatonia. And for delirium, they met the DSM-4. So this was the distribution of catatonic signs that these 16 patients had. They had the typical form of stuporous or retarded catatonia, the same as the old videos from that I showed you, and modern patients that you would see nowadays: mutism, withdrawal, posturing, staring, all the common symptoms of the retarded form of catatonia. So based on this, we posited that there was such a thing as delirium with catatonic features that should be studied as to whether it made a difference in terms of the outcome or treatment of delirium. Now, you might ask, well, how is it possible to diagnose delirium in somebody who's catatonic? Because many times people who are catatonic don't speak at all or speak very little. Well, it is possible, and people have done it. It can be challenging. So on the right here is what we use, which is the DSM-4 criteria for delirium. Disturbance of consciousness, reduced clarity of awareness, with ability to focus, sustain, or shift attention. Don't need to talk. Change in cognition, or perceptual disturbance. So sometimes it's possible even a person who's not talking to know that they're having hallucinations because they're picking at things in the space, or they may have dyspraxia, which is a defect of cognition. Short period of time, evidence from the history. Okay, so it's possible to diagnose delirium in somebody who is largely mute. Can be challenging, but it has been done, and many times it has been done. DSM-5 criteria on the left side: disturbance of attention. Don't need to talk to do that. Or awareness of the environment, don't need to talk to do that. Disturbance over a short period of time, don't need to talk. An additional disturbance in cognition, which could be visual, spatial, or perception. So a person who has dyspraxia, can't button their shirt or show how to use a toothbrush, for example, would qualify for this if they spoke not at all. And then not occurring in a case of dementia, and cause can be identified. So it is possible to diagnose catatonia and delirium simultaneously. It can be challenging, but again, most people with catatonic mutism speak to some degree. So for years, I tried to persuade the consult service at my former hospital in New York to do the study of prospectively identifying, looking for overlap between catatonia and delirium, unsuccessfully. My colleague, Dr. Mormondo, eventually got them to do it after I left. So this paper was published a few years later, and it was specifically inspired by that paper we wrote. This was from Sandeep Grover and his colleagues in India. It's an academic hospital. It's not a true prevalence study. They looked at 205 consecutive consult referrals that seemed to be for delirium. They confirmed delirium by a well-known research scale. This is the Topaz delirium scale, commonly used in delirium research. And catatonia by the Bush-Francis, which is 2 out of 14, or the DSM, which is 3 out of 12. And what they, had clinical and research diagnoses of catatonia and delirium. So 32% of these people with research diagnosis of delirium had catatonia by the Bush-Francis, which is a low score, a low bar, 2, and 13% by DSM-5, which is a higher bar, 3 signs. And the severity scores were correlated. That is to say, the more severe the delirium, the more severe the catatonia. And it was the hypoactive form. Couple of the items on this rating scale assess motor activity. So this was confirmation that catatonia and delirium can coexist in a prospective fashion, although it's not a truly prospective sequential random sample. So around this time, attending the psychosomatics, or now called the Consultation Liaison Society conference, I met Joellen Wilson, who was a resident and fellow in consultation and eventually now faculty at Vanderbilt, where Dr. Ellie is. And she was inspired by that same paper that we'd published a few years before. And I became an outside collaborator with her group, and we published the first paper in a critical care journal a few years ago. So what Dr. Wilson was able to do was to add assessments for catatonia using the Bush-Francis scale to one of the prospective outcome studies of delirium, which Dr. Ellie is frequently running. So this particular study, it was middle-aged and older patients entering the ICU who were not delirious and not catatonic on entry. And during their course of the ICU, they were serially assessed for delirium and catatonia by independent teams of investigators. So Dr. Wilson and her collaborators assessed them for catatonia, independent of parallel assessments at different times of the day for delirium. This was the first wave of this study. So this now is a prospective study of prevalence of catatonia and delirium in a prospective sample of people entering the ICU. So this was now the 136 patients in this first wave of the study. So not surprisingly, these are people middle-aged and older entering the ICU, primarily with sepsis and respiratory problems. Not surprisingly, 42% have delirium. But 31% here had both delirium and catatonia. Only a few had catatonia alone, and some patients had neither. So this, again, confirms in a prospective fashion that delirium and catatonia can coexist. We also learned along the way that there was better sensitivity and specificity by using 4 signs rather than 2 in this ICU kind of population. So that was part of the analysis of this paper. And they met DSM-5 criteria for catatonia and the LE-CAM ICU method for delirium. So later research indicates that the presence of catatonia might afford a worse prognosis for delirium. This is still under study. That's not clear yet. What about treatment when catatonia and delirium coexist? So we have only hints, unfortunately, from this. So this was a study done by Joseph Cooper and his colleagues at the University of Chicago. And they were interested in catatonia on the medical and surgical part of the hospital, not the psychiatric part of the hospital. And what they were interested in is how well is catatonia recognized and what sort of medical workup do they get if it is recognized. That was the focus of the study. It wasn't really on delirium or the treatment. But buried in that study is some data. So this was a retrospective study. They're looking at charts. They're looking at pieces of paper or electronic records, not patients. And they're trying to glean from the record something about these outcomes. So they were able to use electronic record to search text, and they searched text for symptoms of catatonia. And they were able to identify 54 patients. These are medical surgical patients who meet DSM-5 criteria for catatonia. Some of whom were known at the time to have catatonia, some weren't known. And in that sample of 54 patients from the records, they could ascertain that it looked like 29% had delirium, again, from reading the notes. So it was a chart study. From reading the notes, they ascertained they have catatonia and meet those criteria, but they suspected delirium in 29 out of the 54. Most of the paper is about assessment and workup of them, but they also had a treatment. So of those 54 people with catatonia, this is the response to lorazepam. So of those 54 people, 29 got lorazepam. So on this far left column, here are the 29 people who got lorazepam. And 83% got better. Now, what does got better mean in a chart study? When I spoke to the authors, it was an impression from reading the notes. It seemed that both the delirium and the catatonia got better. That is to say, the patients were more alert, functioned better, engaged better. So as best as it could be determined from reading a chart study from the progress notes of the doctors and staff, they made an impression and categorized it into respond or no respond. Okay, so there's obviously weaknesses of that, but that's what was done. So not surprisingly, most of them got better, because that's typical response to lorazepam. On the far right, those are the same 29 patients, far right 2 columns. Those are the same 29 people who got lorazepam, now chopped up into whether they had delirium or did not have delirium. So it's the same 29 people who got lorazepam. So 17 had delirium and apparent delirium, and 12 did not. Again, there's a high rate of response to lorazepam, and it was a global impression of how much they got better, again, from a chart study. And the doses were small, in the range of 2 milligrams typically a day. So this was a suggestion from a kind of retrospective chart study that when delirium and catatonia coexist, at least some patients might actually get better with lorazepam. We normally avoid lorazepam in delirium unless we know it's from sedative or alcohol withdrawal. And we normally don't give haloperidol or other high-potency antipsychotic drugs to people with catatonia. So anyway, this was a suggestion from a chart study. So this was a prospective study. Now we now have quantitative data. So this was Dr. Mormondo and his colleagues at Stony Brook after I left. I'm also a collaborator on this study, which is as yet unpublished. So they screened medical adult patients from admission until discharge. And they looked for presence of delirium and catatonia. Catatonia by the Bush-Francis using 4 signs present, a high criterion, and delirium using the CAM method, Dr. Ellie's CAM method for delirium. So they were able to identify 15 patients who had both research criteria for catatonia and delirium. These were general medical patients. It was an elderly sample, average age of 70. And of those 15 patients, this was a naturalistic study, it wasn't random assignment. Of those 15 patients who now have research criteria for delirium and catatonia prospectively identified in the medical floors, elderly sample, 7 got lorazepam and 8 did not. They were elderly, in their 70s or early 80s. They were mostly female. They all had delirium. And here's now quantitative data on their Bush-Francis catatonia score. So they had scores that weren't different, 14.3 versus 11.4. They had naturalistic treatment. It wasn't prospectively identified, wasn't prospectively assigned. It was naturalistic treatment, wasn't randomly assigned, but there's quantitative outcomes. So on the left panel on the bottom, these are the people who had delirium and catatonia who then received lorazepam, and the doses were 2 milligrams and less per day, typically. So the blue bar on the far left is the initial catatonia score. The red bar is after treatment, before discharge. There was a significant and statistically and clinically significant drop in the catatonia scores. Also, they know most of them no longer met criteria for delirium. So both the delirium and the catatonia got better in this sample. On the right-hand panel, these are now the patients with delirium and catatonia both, who never got lorazepam. Their catatonia didn't change, and they remained delirious. So it's a little bit better of a hint, at least it's prospective and naturalistic with quantitative data. So we're lacking a truly randomized trial of treatments for catatonia and delirium when they coexist. So let me conclude here and leave time for some questions. Catatonia is a distinct syndrome associated with morbidity and potentially mortality if severe and persistent, often responds to treatment if diagnosed, and looking for it in new populations such as delirium or developmental disorders is important because it's often very treatable and contributes to better functioning of the patients involved. Catatonia and delirium may coexist. We don't know yet. We have hints about how to treat it. There's a variety of treatments that could be offered. Let me stop there and we'll take some questions and discussion.
All right, let's see. So we have a couple people
Okay.
raising their hands. So I'm going to promote them to panelists so they can ask their questions to you, Dr. Francis. All right. Oh my gosh. Okay, yeah, there's a lot of people. Give me a second.
That's fine. That's fine. The more, the better.
Yeah, absolutely. I agree. All right. I'm not sure who wants to go first. But does someone have a question for Dr.
Can you
Francis?
hear me?
Yeah.
Hi, Dr. Francis. This is Syed. I'm one of the fourth-year residents. One question I had, thank you so much for doing this presentation, and it's really interesting to kind of review the scale and everything. One question that I had comes from recent experiences in treating catatonic patients, and the question about either challenge or maintenance of the catatonic symptoms with either IM, PO, or IV Ativan, and just trying to find some primary literature on it past the paper by Friccioni in the 80s. I wasn't really able to find much on what would be the more preferred method,
Well,
or even the dosing. If
right.
you go with IV versus IM or PO.
Well, so oral intake is very questionable in people who are it's questionable in general, but it's questionable certainly in people who are catatonic. So parenteral, if you're doing a diagnostic challenge, a lorazepam challenge, far better to use parenteral treatment if it's all available, because then you know the drug got in. So far better to use IV if that's available, or IM over oral.
So if you start somebody on Ativan and you escalate it and they have resolution of their episode of catatonia, how long should they remain on benzodiazepines, and how do you taper it? And what if they have reemergence of some catatonic symptoms as you do so?
So the answer to that is complex. One factor would be, do you know why they have catatonia? So if it's a quote organic unquote catatonia, and that is a self-limited thing. So for example, so-called steroid stupor, people who have corticosteroids and develop a catatonic reaction, and they don't have a need for ongoing corticosteroids, those people probably don't need to be on maintenance treatment for catatonia. So there are some quote organic unquote, to use an old language, catatonias where there isn't any need for sustained treatment. Catatonia in the autistic population, they seem to need a sustained ongoing treatment. People with bipolar disorder, it's iffy. It's a variable. It's sometimes associated with mood episodes, commonly mania, by the way, more than depression. And with schizophrenia, it's also a variable. So it may, part of the quote underlying diagnosis is one of the factors. The second factor is, are you going to need an antipsychotic drug for whatever you think is their diagnosis? If you do, I would try to, best I could, to defer adding an antipsychotic drug until the catatonia is resolved or largely resolved. Keep the benzodiazepine going, if it was lorazepam, for some period of time, and watch closely for extrapyramidal or catatonic symptoms. There's some evidence that a serum iron test can predict worsening of catatonia from a neuroleptic. And although there isn't a good literature to underlie this, there's just clinical wisdom, use an atypical. How long somebody needs to be on lorazepam, they should have a trial off of gradual taper and see how they do. I've had people on low dose lorazepam, 2-3 milligrams a day for 20 years. Never abused it, never got tolerant, and their catatonia remained in abeyance. So this is a clinical judgment. There isn't good literature, and there probably never will be, to address that question. But those are the factors I would consider: the underlying diagnosis, whether an antipsychotic is needed, and a trial off, or a trial of tapering, not off, tapering. I'm not sure that answers the question. There isn't good literature base on that. Only clinical experience.
Dr. Francis, can I mention something about ECT?
Oh, sure.
Well, first of all, happy New Year, and thank you for coming to Kentucky. Welcome.
Yeah, I wish I could be in person.
I'm going to talk about something that's from about 20, 25, 30 years ago. I don't know exactly.
Mhm.
We used to do a good bit of outpatient ECT, and I had one patient of particular interest who used to respond to a single shot of ECT.
Uh-huh.
But the interesting thing was his family, he had the passive form, like you described it. He didn't resist, but he was completely passive. His
Yeah.
family would bring him in maybe once every year or two.
Mhm.
We did a VHS tape on him saying, if ever I get catatonia, tell Dr. Lipman and get
Yeah.
ECT for me.
Yeah.
And his family would bring the VCR tape to the ER. They would play it. And he says, this is my informed consent beforehand while I was in good mental status.
Yeah.
They would call me and I'd come in the morning and we'd do a shock treatment. He'd go home and I wouldn't see him except in clinic, or maybe he'd pop in a year or two later and need
Now
another
this
ECT.
must have been a robust form of ECT that is often not used today.
Just old standard stuff. But I will say, speaking of robust, I knew a doctor who was still, he's older, I'm 80. This guy was old when I was young. He said he used to give the ECT before they used the modified drug,
Yeah.
modified ECT. And he said he thought it was better than the treatment that we give. But I never tried it.
Yeah,
I just did standard ECT, but I always did bilateral. I never did unilateral. I found that the unilateral guys were doing a whole lot more ECT per person than I did.
Yeah.
And I figured if the biggest chance of risk was the anesthesia, maybe it was better to do the bilateral. I only did bilateral.
Right. Well, the research literature, published literature favors bilateral. There are a couple of case series and case reports that unilateral work. There's also case reports that unilateral did not work, and they had to shift the patients to bilateral. So certainly when catatonia is quite severe, we always use bilateral, unless there's some compelling reason not to, at least to start. And we may occasionally switch people to the unilaterals once they're better, so to speak. We have a lot of people on maintenance ECT for a variety of things, for mood disorders, for catatonia, with autism and catatonia. And that maintenance schedule is highly idiosyncratic. We have people who are coming for mood disorders, for example, who are coming every 8-9 weeks. We have people coming every 2 weeks. And it's there's no cookbook on this, to my knowledge. It's empiric of trying to gradually extend the interval and watching how the patient does. But the good news is, and we've seen this many times, if catatonia, well, in general with ECT, across diagnoses, if it worked before, it'll work again. Unlike certain antidepressants that poop out, so to speak. We don't really see that with ECT. The same is true for catatonia, that if a person was catatonic in the past and responded to ECT, they tend to respond robustly again with a future episode. But thanks for your input on that.
Yeah. By the way, when you were at Penn State, we had one of our doctors, Karim Sitki. Was he ever with you?
No, I've only been here 9 years. I was in New York prior.
Okay. He's now at San Diego, but anyway. All right. Well, thank you very much. Very interesting. Thank you for doing this presentation.
Thanks for the compliment. Other questions? I see hands up.
Yeah, hi, Dr. Francis. Yeah, hi. I have a question. So would you care to comment about the possible mechanism of catatonia, like in the sense of evolution, neurology, or psychology? Sort of, has anybody done like neuroimaging studies, with catatonia patient before and after?
Okay, so I can do both. So I don't do brain imaging or biological kinds of research, but I read such literature. Disappointingly, I might add. So there's a variety of biochemical studies of catatonia. having to do, first of all, there's anatomical studies, old literature from, can we learn anything from localized brain lesions? This was Mickey Taylor in the 90s, a review paper of all the case reports of people who had local, not generalized, local brain lesions from tumors or strokes. Can we learn anything about biology of catatonia from local brain damage or injury? And the answer was yes, it's more likely lesions of the frontal lobe and basal ganglia are associated with catatonia. There's some genetic studies that fell apart. There's some biochemical studies looking at monoamine metabolites that seem to be increased, as if there was more dopamine activity, so to speak, especially in lorazepam responders. Brain imaging is hard to study because the patients can't consent. Most IRB panels, human subjects panels, frown on non-therapeutic research in non-consenting subjects. So if you're motivated to do a brain imaging study of catatonia, which is well worth doing, while they're severely catatonic, attach it to a treatment, and the IRB might let you do it. So far, that hasn't been done. Most of these brain imaging studies are done in partial recovery when the patient's well enough to sign a consent. So there's some evidence from a PET study using a, I'm not sure if it was a PET study or a nuclear study using a ligand, a positron ligand for GABA-A. Must have been a nuclear study. Decreased GABA-A binding in parts of the cortex, actually asymmetrical left and right, consistent with GABA-A agonists treating catatonia. There's recent fMRI studies, again, mostly done in recovery or partial recovery when the patients could consent, showing abnormalities in frontal areas and supplemental motor areas. Dr. Georg Northoff, Northoff, who's now at the University of Ottawa, has published a lot on this, and his papers. I do want to talk about the psychological theory because I like it. I like to, huh?
Physically screen printed. Is it like the paint that goes on your shirt and has to dry?
Okay, I didn't hear the question. Was that a question?
Yes,
I think
that's a
it's
question.
noise.
Okay, so I'll just talk about the psychological theory, which I love to knock. So this was published by a psychologist in Australia, Moskowitz, and the idea was that there's a psychological model of catatonia derived from animal analogs frozen with fright. So a animal on the approach of a predator will freeze because predators are attracted to motion. While frozen, they actually have some catatonic signs. Their blood pressure and heart rate go up, and they're not moving and not talking. Okay, is that someone asking a question or?
No, I would just recommend that panelists please mute your microphone if you're not speaking. Thank you.
Okay, so the argument that Moskowitz made in this article was that there were animal analogs. There's also something called tonic immobility, something in chickens and other birds. But anyway, the idea was that an animal that is under attack from or potentially under attack from a predator or has been injured will not move, not talk, not make any noise. And also that there's evidence of a fear reaction. And so the support of this in the animals. So in support of that, that is to say there's animal analogs of fear. So in support of this, there's animal analogs of this idea that anxiety and fear are the basis of catatonia. So it is true that many, but not all patients who are catatonic, when catatonia resolves and you interview them, they will often describe, but not always, some sort of distressing or anxiety-provoking experience. And it is true that medicines such as benzodiazepines and barbiturates relieve catatonia, but they also treat anxiety. So it sounds great. It sounds like a terrific theory. But here's the problem. So if you are a mouse walking in a field and a hawk flies over, you freeze and hope the hawk doesn't see you and goes by. But if that hawk approaches you, you turn around and try to fight the hawk. So that frozenness goes away in an instant if the predator actually approaches you. And if the hawk flies by, the mouse runs to hide somewhere. So that frozen with fright does exist, but it's seconds and immediately turned off. Whereas catatonia can be chronic and fatal, can last days, weeks, months, and years and be fatal. So the timing is all wrong. Yes, treatments for catatonia, barbiturates and benzodiazepines relieve anxiety, but the doses are all wrong. So the dose of lorazepam to treat anxiety might be 1.5, 2 milligrams a day. But the dose to treat catatonia can be 15 or 20. The doses are all wrong. ECT is the best treatment for catatonia, but it is relatively useless for anxiety. And the lastly is a fallacy, a logical fallacy. So anxiety and fear is a symptom of catatonia for many patients, not all. But it would be a complete error of logic to say that one symptom is the cause of all the other symptoms. So this psychological theory is appealing at first blush, but I don't buy it for the reasons mentioned. Other comments or questions?
Dr. Kalil, one of our inpatient attendings, has had his hand raised for a while, so wanted to make sure we recognize him.
Hi, this is Dr. Kalil. Just one question. I've seen some anecdotal reports of IV ketamine for catatonia. Do you have any experience with that and any comments about that?
I wish it did work. I haven't. We have a person right now that we're treating in the ICU who's on a ketamine drip with catatonia, and the ketamine does not make him any better. So, I mean, obviously, it's a more massive dose. So I don't have any experience with that. There's reports of hallucinogenic drugs, PCP, for example, and there might be some reports of ketamine also causing catatonia. I'm not sure about that. PCP for sure. There's a literature on that. So I don't have an answer to that. It would surprise me.
Yeah, I just want to make one other comment that Dr. Lippman made a little bit earlier about ECT and catatonia. I do ECT here at University of Louisville, and I've actually had a lot of success with doing right unilateral for catatonic patients, even patients who are medically hospitalized and pretty severe. Of course, some of those have to be escalated to bilateral, and quite a few still need bilateral anyway. But there is, if you look at there's a lot of docs in the country who are using a lot of right unilateral for catatonia. It's been successful.
Yeah. I would be cautious about doing that, and for somebody sick enough to be in the ICU, though. But if you have that literature, you have case series, you should publish that.
Yeah, that's what we're thinking. And but most of the ICU patients, they were all bilateral, but patients who are like maybe in the medical floor, a little bit less severe. I mean, very good success rate with the right unilateral.
Yeah, I think that should be published.
Hi, Dr. Francis.
Dr. Francis.
Yeah.
Sorry. Sorry, Will. I think Dr. Bonomo and Dr. Chopra were up next. They've had their hand raised for a little while.
Well, thank you, Dr. Francis. I'm glad to meet you. I'm here. My name is Dr. Bonomo. This is Dr. Chopra. It's an honor to have you talk with us. There are a lot of questions that I have, but there's one thing in particular I've been thinking about a lot lately. You know, I've noticed that patients that have catatonia that are managed with benzodiazepines, they often do much better in the long term if you can get them tapered off of those medications, which obviously can be difficult in a lot of scenarios. Do you think there is a role for neuromodulation, particularly ECT or low frequency repetitive TMS, so the SMA, to help with benzodiazepine tapers so that patients may have a better long-term prognosis?
Well, certainly maintenance ECT is well known clinically to be useful for mood disorders and also for catatonia, and we've treated several and have ongoing treatment with several currently. So that we know. With respect to the newer neuromodulation non-convulsive techniques, TMS or various low-level electrical stimulations of different parts of the brain, there's case literature appearing on that. I'm not familiar with it. I'm skeptical, but look forward to seeing what can be learned. So I mean, I think it may be helpful. I would point out, though, that even with bilateral ECT on a maintenance schedule, and maintenance schedule means a few weeks or longer, patients don't experience cognitive side effects. They have an anesthetic effect. They go back to work or school the next day. So the cognitive side effects of ECT are mostly related to the frequency of the treatments. So when you have ECT on a maintenance schedule, and maybe Dr. Caliel has a different experience, people on a maintenance schedule don't complain about cognitive side effects. They have an anesthetic effect. That's it. When they're getting ECT every 3, 4, or 5 weeks.
I've noticed that as well. They actually, sometimes their cognition does much better with maintenance ECT.
Yeah. Yeah.
Dr. Francis, I'm Dr. Chopra. And I'm very honored to come on your grand rounds.
Thank you.
This is the first grand rounds I've attended since I've left. I was very excited when Dr. Nicholas said, well, Catatonia. So I said, yeah, you need to read about Max Finks. He is the grandfather of ECTs. He's written on pediatric ECTs. He's had a national consensus. You know, you get everything. He knows everything all, you know. And then, well, I practiced.
By the way, let me interrupt you for a second. So if any of you happen to be at the American Psychiatric Association last May and September, we had the Max Finks Centennial Symposium, which I chaired. And Max was 100 last January. He'll be 101 next week. And we had a panel of speakers, including myself, who'd had experience work with Max over the years, including Dr. Friccione, who was mentioned. And we even had a segment with Max. Max attended by Zoom, as did his family. And I did a little interview with Max, like a 10-minute interview with Max too, for people who had never met him, to see. He does not come across as your impression of a 100-year-old man.
He's on your website, on your website?
I'm not sure where this video is, but there is another video of Max.
Your interview, is it there on your webpage?
No.
Okay.
No. I might look if I can install it. Yeah.
Yes, sir. And Dr. Francis, there's an article called Where the Catatonics Gone.
Yeah.
And you know, I was practicing from the mid-80s to mid-90s in India. And it's more common in, it's pretty endemic in psychologically naive communities, you know, rural areas. And
Yes. There's actually a study of that. It was done by some researchers in Wales who were of Indian heritage. And the doctors examined patients in Wales for prevalence, and the same doctors who were Indian and spoke languages went to India and did the study, and the rates are about twice as high.
Yes, sir. And you know, the primary care the private doctors, physicians, they're so familiar with it.
Yeah.
And they would diagnose it for me, get all the CT scans, MRIs, and all that stuff. They would diagnose, and I would go wake up early in the morning at 4:35, go from one private hospital to the other hospitals, giving ECTs for catatonics. And it's one of the most dramatic treatments in the history of medicine.
I certainly agree with that. I've been doing
just like a cardioversion, you know. I've treated 2 patients in the ICU. One had treatment refractory DTs. In fact, his last sacrament was done. He was dying. He was gasping. So finally the cardiologist said, "Man, you must come over, man. You need to know. We've given that IV diazepam continuously on the day, and he had bed sores on his scalp and on his heels.
Yeah,
he was strapped." So I said, "Well, you know, delirium is a psychotic state. It's hallucinations, delusions, and agitation. Well, I give me when we'll be left, but it's pretty. I mean, he's terminal, you know."
Yeah, there is a case literature actually on use of ECT for delirium that doesn't respond to other treatments.
This guy was an alcoholic. He drank through the year. On the Lent, he would quit, you know.
Yeah.
And then the anesthetist came and she said, "I'm not giving anesthesia, man. Let him die in peace." So I said, "Well, just pray for me." We give a direct ECT. He convulsed for about 30, 40 seconds. He aspirated a lot. He had bronchopneumonia. And, he was cachectic, dehydrated. And he recovered. He sat up the next day.
Yeah. So I've been doing ECT for 31 years now, and it still amazes me. Now, sometimes it does nothing. Sometimes it doesn't help the patient. But when it does work, it's so dramatic. It's just.
And you got to use the sine wave bilateral, you know.
You can't get a sine wave machine.
You can't beat that, sine wave bilateral, you can't beat it. And
I think there's some other questions.
Yeah. So it is a couple minutes after 1. We're going to have to end things here. Residents and medical students, if you guys could stick around. Thank you all so much, or thank you so much, Dr. Francis.
I'm happy if someone would collect questions that people have and then mail them to me, I'll respond.
Absolutely. Yeah. Audrey and I are happy to do that. If you want to, I have your email. Is that okay if I give that to everyone for them to email you directly if they have questions?
I think so, yeah.
Okay. Okay, cool. That makes sense.
I'm a New Yorker. I can handle it.
All right. Very good. Very good. Yeah. All right, everyone. Thank you so much. We'll see you next time.